This 81-year-old patient was referred to me for endodontic treatment of tooth number 30. Crown, patient says a few days ago, crown came out, and she went and saw her dentist, and her dentist told her that she had a big cavity under the crown and went ahead and re-cemented the crown with temporary cement and referred the patient to me. Now, you tell me what's wrong with this picture, okay? So if you have a patient who comes to you and with a crown that's come out and they're holding the crown and you look at the tooth and you say you have a big cavity, would you just go ahead and slap that temporary crown back on, or would you just do caries control, clean out the decay, and perhaps maybe prep the tooth for a crown, put a temporary crown on it, and then refer the patient to an endodontist, such as myself? Well, usually that's not the case. Usually I have to do caries control myself. I was a general dentist for 5 years before I became an endodontist, went back to university and hospital and got my training and all that stuff. I was a general dentist, and I would do that. I would do caries control, make sure patient's oral hygiene was good. If I had to do cleaning, clean, do my cleaning, scaling, root planing, if I had to do all of that stuff, caries control, and then refer the patient to an endodontist, because I would get embarrassed. I would say, the endodontist would look at this and say, this guy. So I always wanted to present my cases, my patients, and myself very well. Anyways, it is what it is. You can't change people. So as you can see, extremely calcified canals. I can't even see the mesial canals. I can see a little bit here and then disappears, a little bit here and disappears again. Distal, there's no pulp chamber. So if you're looking for a pulp chamber and the typical drop of the burr in the pulp chamber and giving you the signal that you're in the pulp chamber, you don't get this. So this was microscope from the beginning till the end. Ultrasonic shaving of the mesial area to hit the canals, the mesial canals. This all I found almost immediately. So this patient could open this much. I swear, we could not fit a small child-sized bite block in her mouth. We could not fit a small child-sized bite block in her mouth. She was 81 years old, as I said. So I put the rubber dam on, and as always, try to go through the crown. The crown pops right out. So I'm like, oh, okay. And again, this patient can open only this much. Now my molar clamp is not grabbing the tooth because the crown is gone. So I used the premolar clamp, clamped the tooth, rubber dam, and cleaned out all the decay there, rebuilt that distal wall, and I could see that I had pulp exposure. And by the way, it was a necrotic tooth. Pulp exposure, I could see that there was pulp. There was not pulp exposure. The pulp was necrotic, but I could see the orifice of the distal canal. All right, so once I found the orifice of the distal canal, then I used geometry, triangulation, and I was able to locate the orifice of the mesiolingual canal. I found the mesiolingual canal next, and then I used the mesiolingual canal, the distal canal, that triangulated, and I had to dig really deep with my ultrasonic and of course microscope to hit. I had to dig really deep to hit the mesiobuccal canal. So cases like this, I always tell the girls, put the patient last, because this case took me about an hour and 5 minutes to do from start to finish. So take a look. And here's the post-op. So as you can see, everything went beautifully. The radiographic apex of the distal root is here. That's where the radiographic apex is. Look where the actual apical exit, apical foramen is. Okay, these are the things that you need to pay attention to and know. You know, I always say you perceive the world based on your knowledge and experience and expertise. So you need to recognize all of that. This is not a case that a general dentist and a novice wants to do. This is not a case that a beginner general dentist or intermediate general dentist wants to do. You know, I recommend, even if you are a really good endodontist and you do a lot of your root canals, these cases I recommend that you refer out. You can easily perforate a tooth like this with the patient's opening this much, you know, less than a 2-year-old kid. We can fit that small child size bite block in a 3-year-old's mouth. And we couldn't fit that in this patient's mouth. We could not. So these are not the cases that a general dentist really wants to tackle. You can use your time and energy doing a lot of other things, a lot of more productive things than spending time on a case like that. Anyways, as you can see, everything went beautifully. Went ahead and temporized the tooth and referred the patient back to her dentist. This is an important tooth for this patient because if this tooth goes, then she doesn't have another tooth to chew on. This number 30 is a very important tooth. I'm glad we could save it for her.